Good day to everybody. My name is Dr. Vinicio de Jesus Perez. I'm an associate professor and staff physician at the Pulmonary Hypertension Center of Excellence located at Stanford University Medical Center. I am a physician scientist with a passion for understanding genetic molecular mechanism of pulmonary hypertension with the ultimate goal of identifying new treatment strategies based on genetic and molecular targets. Today, I want to tell you about some of the most recent clinical developments in the field of pulmonary hypertension, highlighting new and ongoing clinical trials that are of great interest to ourselves who work in the community, as well as caregivers and patients who are looking forward to novel ways of treating their condition. I want to start first off by highlighting a drug that has been in the public domain now for a while, and many people, including patients and caregivers, have probably heard of, which is called sotatercept. Sotatercept is a new drug that has now completed both phase 2 and phase 3 studies. So it's quite advanced. It is at the point of being evaluated by the FDA for approval, which will mean that this drug may be entering our treatment armamentarium over the next year or so, hopefully. What this drug does, which is quite different from the other 14 approved drugs that we are currently prescribing patients, is that while all the other drugs are usually what we call vasodilators, that is medications that relax the blood vessels to allow more blood flow to go through, what sotatercept is doing is actually targeting the cell growth, the buildup of cells that ultimately closes the lumen through which blood needs to flow. We believe in pulmonary hypertension that as the disease progresses, more and more of these cell-rich lesions build up inside the blood vessels. And so what the vasodilators do is mostly they target vessels that are still functional, that even though they may have some vascular changes, they can still be open enough so blood can be diverted through them so that they reach out the areas involving gas exchange. However, as the disease progresses, these vessels too become encroached by these lesions, and ultimately the number of vessels available to be open become less and less. So sotatercept takes a new paradigm, which is rather than working on those vessels that can still be vasodilated, it's targeting vessels that are already occluded, with the idea that if we can possibly melt away the cell growth inside the vessels, we can restore the patency and allow more blood to go in. That will work very well for the heart because the right ventricle will not have to put so much effort to get blood into the lungs so that it can get oxygenated. So sotatercept is an injectable drug that is given every 3 weeks. This is one injection that goes under the skin. It's a subcutaneous injection. It's different also from the other injectables like Remodulin sub-Q and intravenous or Velitri, which have to be given continuously. Here we're talking about an injection that's repeated every 3 weeks. So in that sense, it's also quite different to other drugs. How does sotatercept work? It's actually based on mechanisms that are based on our discovery around 23 years ago of the most common genetic mutation in pulmonary hypertension, which is around the bone morphogenic protein receptor 2 or BMPR2. This gene is crucial to control the growth and viability of cells across the vessel wall, endothelial, smooth muscle cells. Mutations that result in loss or dysfunction of these receptors are associated with abnormal cell growth that leads to pulmonary hypertension. What this drug does is actually restores an imbalance that exists in the cells where the lack of this BMPR2 signal is overwhelmed by activation through other alternative pathways. In this case, pathways that are responses to other ligands like activin. Sotatercept is what we call a ligand trap. Essentially, it's a little antibody-like peptide that binds to the activin proteins and prevent them from triggering these abnormal or pro-PAH pathways, thus restoring a balance. We have now 2 clinical trials that have been reported, and I must say the results are quite exciting and have increased hope in the field that we are entering a new age in the way we treat the disease. What we have found is, just to highlight the most relevant findings, number one, that even in patients that are being treated with 3 different therapies, the medication can add significantly greater benefit, both in reducing pulmonary pressures, increasing 6-minute walk, reducing the risk predictors for mortality, reducing hospitalization, and allowing patients to be able to do more and expect more from their medications. Again, I want to highlight that this is most of the patients, over 60% of patients in both trials were already on triple therapy, including subcutaneous and intravenous, which, as you guys probably all have heard, are the best, most potent medications. So this medication can be added to provide a benefit that's in addition that can potentially allow patients to be able to carry out and have a better functional status beyond what can be offered for the current standard of care. This medication was also studied in patients who are on dual therapy and can be added as a third-line agent. So what we're seeing is that sotatercept can be used either as a third-line or a fourth-line agent. Now, the big questions, of course, is, well, how late or how early can this drug be started? There are 2 ongoing clinical trials that are exploring precisely that, and they're currently recruiting. Now, beyond pulmonary arterial hypertension, which, of course, we're talking about idiopathic, connective tissue disease, drug and toxins, congenital repair, what other indications could sotatercept help with? One of the unmet needs in the field is what we call group 2 pulmonary hypertension, which is the most common form of pulmonary hypertension, and that's the one associated with left heart disease. So diseases such as left heart failure, valvulopathies, pericardial restriction, all of these disorders that we currently have no treatment for because we know that the standard of care for pulmonary arterial hypertension is contraindicated in this group. So at this point in time, we're really left with not much other than experimental therapy. So there's an ongoing clinical trial called Cadence, which is exploring the use of sotatercept in this patient population as a way to offset the impact of pulmonary hypertension in these patients. And this is, as I said, a very complex cohort of patients. So having a medication that can potentially help improve outcomes and quality of life in these patients will be revolutionary, to say the least. Another area where sotatercept could be useful is in the treatment of pediatric patients with pulmonary hypertension. As you all know, many of our drugs have been studied in adults. Very few are studied in children, which of course creates a lot of conflict when it comes to figuring out the best dose and the best regime for which we can offer. Well, sotatercept is also being studied in pediatric patients, which again is a very refreshing initiative since we are in dire need of studies to look at that very unique patient population, which is quite different from that of adults. So There's a lot of excitement around this drug. As I said, I think the clinical trial data is quite compelling, and the data is currently being evaluated, to the best of my knowledge, by the FDA for potential approval. So we're very hopeful that we may see this drug in clinic over the next year. That's sotatercept. The other drug class that is currently being studied in clinical trials are what we call the tyrosine kinase inhibitors, or TKIs. The best known of these is imatinib mesylate. Now, imatinib mesylate 15 years ago was being actively studied in its oral form for the treatment of group 1 pulmonary hypertension. And despite very promising data, including a phase 3 clinical trial that met its primary endpoint, unfortunately, the drug was plagued with significant side effects, including episodes of head bleeds, which ultimately led to not pursuing this drug further. However, as I mentioned, it has to be highlighted that the drug did meet its primary endpoint. So how can we get all the benefit of the drug while bypassing the toxicity, which will prevent our patients from being able to get the benefit that the drug provides? So over the last 5 years, we have seen the development of imatinib and another drug within that class called seralutinib as inhaled agents that the patients can use to deliver the compound to the lungs themselves, much akin to what we have now with Tyvaso. So the clinical data right now, well, we have a phase 2 study that was recently completed with seralutinib. This is a drug that's delivered twice daily by inhalation. And the primary endpoint for this trial, which was called the TORREY study, was to see whether the drug could reduce pulmonary vascular resistance, which is an important surrogate marker for phase 2 studies. And what we found is that the drug did meet that primary endpoint. Again, in a patient population representative of our current PH standard of care, including 2 or 3 agent use. With imatinib, we also have data now showing that indeed, as seralutinib, this inhalable compound seemed to be safe, which bypasses a lot of the anxiety and concern raised due to the previous results that we had, including the phase 3 imatinib study that I referenced previously. So right now, we're seeing that the seralutinib studies are moving to a phase 3. It will start recruiting soon. And there are 2 companies currently developing imatinib for inhaled use that are also now moving towards phase 2. So these are drugs built on solid preclinical data and already very strong clinical data showing that they have clinical efficacy that can be used. So if we can harness that benefit and avoid the toxicity that is seen with the drugs, we can certainly provide an alternative treatment to our patients that also targets the cell growth and mechanisms that lead to the vessel obstruction. Now, these 2 are the most advanced of the current medications that we have. I want to close by pointing out to other clinical studies that are either enrolling or are close to completion, and we are waiting for the results to be publicly announced. The first study is the anastrozole study, which is also known as the Phantom study. This study is built on the premise that estrogen metabolites can contribute to pulmonary hypertension and may explain why females are more prone to develop pulmonary hypertension. So the hypothesis here is that anastrozole, which is an estrogen synthesis inhibitor, may actually reduce the amount of circulating estrogen in both men and women, thus allowing for patients to gather benefit. This is built on promising phase 1-2 data And now we're waiting to see the results of this clinical study. The other study that is really intriguing is a study using a serotonin inhibitor called rototristat, also an oral agent. This agent can inhibit serotonin, which is one of the best known and well-characterized triggers of muscularization and vessel remodeling. We have failed to be able to target this molecule because most compounds cross the blood-brain barrier. Serotonin is a neurotransmitter and it's critical for the brain to work. So you don't want to shut it down completely. What rototristat does is that it actually shuts down serotonin selectively in the body while leaving the serotonin in the brain alone. So it bypasses a lot of the toxicity that historically has plagued this compound. This is a phase 2 study that is currently active, and we are excited to see what the outcome is. The last study I'm going to point out is, of course, a stem cell study. It's relevant because many patients ask me always about where are stem cells in the treatment of pulmonary hypertension. There's a study currently ongoing in Canada. This study is called the phaware study. It's been going around now for the last 5 years, where endothelial progenitor cells extracted from the blood of patients are genetically engineered to express nitric oxide synthase. In other words, the cells can produce vasodilator that can allow the vessels where the cells hone in to vasodilate. And also, since these are endothelial progenitor cells, the idea is that these cells can differentiate into endothelial cells and potentially grow brand new vessels, which is important since one of the major pathological hallmarks in pulmonary arterial hypertension is progressive loss of distal microvessels. So the trial is still ongoing. There's data already. Phase 1 data was published now almost 10 years that show that this approach was safe. It had an efficacy signal, but given the small number of patients in that study, this particular study that's currently ongoing seeks to provide a more solid, definitive proof that this approach is not just effective, but also safe. There's a lot we can talk about other therapies that are currently in development, but I think for the purposes of this conversation, these to me are the ones that are most relevant given how advanced they are in the process of being evaluated for clinical study. Thank you all for listening. It's always a pleasure to share my time with you all. I want to thank phaware again for giving me the opportunity and also to emphasize that I'm aware that my patients are rare.